So I'll jump right ahead into talking about new approaches to treatment in post-surgical and metastatic melanoma patients. I'm only going to focus on clinical research that we're doing over here right now because Ruth covered a lot of the basic science stuff, although there is a lot else going on in other labs as well. So I would say that 2011 was a historical year in our field. Until then, we really had very little to offer. The standard of care was these old chemotherapies. Dacarbazine was considered the first agent to use. It was FDA approved in 1976. It's not particularly effective, although there is a rare subset of patients in whom it is. These are the other drugs that were used in the past. Interferon alpha can induce responses. They're typically not durable. And then high-dose interleukin-2 is a therapy that really helps a very small subset of patients, but when it does work, it seems to work really, really well, and those responses can last for a very long period of time. This is a slide that I took from a paper that was published in the New England Journal of Medicine in 2004, and essentially it summarizes all of the randomized trials that were done up to that point for patients with metastatic melanoma. And if you really look at the small print, I don't expect anybody to be able to see it, it was negative study after negative study after negative study. None of these trials ever showed an advantage to one therapy over another. So it wasn't for lack of trying on our part or lack of trying on the parts of the patients. We just did not have the right agents until fairly recently. So until then, we really felt that the standard of care was a clinical trial. And that may still be true. I'm going to try to make that argument as we go along. These were the older treatments that we did use that I've already gone through. But recently, the FDA approved two drugs. One is the BRAF inhibitor. We just heard from Ruth about BRAF, which is that oncogene that is active in about half of the patients with melanoma. The first drug that was approved that targets this particular BRAF mutation was called first PLX4032, then it was given the name vemurafenib, which is actually kind of clever. It stands for V600E mutated RAF inhibitor. I don't know what Zelboraf is supposed to stand for. And the other one is the anti-CTLA antibody, which is called ipilimumab or Yervoy, and those I cannot try to explain away. I don't know if Dr. Schnoll knows. So this is just a schema of a cell. You have receptors at the surface of the cell. This would be the cell membrane. It's very similar to what Ruth showed. It's just a different kind of a cartoon. You've got receptors on the surface of the cell, and they start signaling into the cell to promote growth, cell division, and so on. So BRAF is one of the most common, or actually the most commonly identified mutation in melanoma, 40, 50, 60%, depending on what study you look at. NRAS is the other one, and then c-KIT is the third one that was mentioned. So when we talk about targeted therapies, we're talking about therapies that attack the seeds of the dandelion. When we talk about immune-based therapies, we're kind of talking about the soil. So to use Steve's analogy, if the dandelion seeds are spread over your lawns and your neighbor's lawn, and they may grow in one lawn and not in another, if they're genetically the same seed, why do they grow in one lawn and not in another? It may actually be the soil or the environment. In this case, it's the immune system. So this specifically is a mutation in the melanoma cell. And there are now two inhibitors of this particular mutation. There's the Plexicon drug or vemurafenib that's already been approved, and then there's another one that's coming through the clinical trial pipeline now called GSK 2118436. It's called dabrafenib as well, and probably this drug will be FDA approved over the coming months as well. We see very dramatic tumor shrinkage in over 50% of the patients whose tumors have these BRAF mutations, but it does not work in the other half of the patients whose tumors do not have the BRAF mutations. This is a graph of survival curves. So every dot on the graph is a patient, and as it drops, it sort of represents a patient coming off trial or a patient dying. So the yellow line is for the vemurafenib, and the orange line is dacarbazine. That was the standard of care on this trial. So essentially, when we do a clinical trial, we start with a small group of patients, and we say, okay, the drug can work in animal models or preclinical models. How much drug do we give? And we do what we call a phase 1 trial, where we give a small group of patients one dose, then we give another 3 or 6 patients a higher dose, and so on, and we push the dose up. That's a phase 1 trial to determine how to administer the drug and what doses to give. Then we move on to what we call a phase 2 trial, where we give a group of patients the drug, and we want to see if the drug is actually active. The third question we ask is it better than what we already have? And those are phase 3 trials, and that's essentially what leads to drugs getting approved by the FDA. So this figure is from the phase 3 trial, where vemurafenib was compared to dacarbazine, and this is the trial that led to that big article on the front page of the New York Times saying that it would be a little unethical to give patients dacarbazine if we can give them vemurafenib, and we know that it might work. But be that as it may, the trial was conducted. That was the way that the FDA mandated that they did it, and the drug was approved last year. The beauty of these drugs is that they're oral pills. Basically, patients take them at home. The toxicities are somewhat chronic but fairly mild, so they can cause a rash, diarrhea, arthritis, asthenia means fatigue, fevers, and so on. The problem is that these cells are very clever, and with time they tend to develop resistance. So median duration of a response is in the order of 6 months. That means half of the patients have responses that are shorter, half have responses that are longer. And there is a subset of patients that probably has a fairly long response, may even be in the order of a couple of years. The other nice thing about these drugs, if we talk about them in combination with immune therapies, is that we think that the mechanism of action is not overlapping, and also the mechanism of toxicity is not overlapping. So going forward, we're going to be using these drugs in combinations. They're not completely benign. They do cause side effects. One of the more common side effects is squamous cell carcinomas of the skin. These tend to not be terribly invasive, so they can just be removed, and people need to be monitored very closely. We keep Jennifer Choi very busy with this. And this is a patient of Dr. Schnoll's who developed a squamous cell carcinoma in the head and neck at a time that his disease everywhere else was basically shrinking on the vemurafenib. So we do need to monitor patients very closely for these side effects. This is the other drug, the GlaxoSmithKline drug. It's now completed phase 3 trials, and as I said, hopefully it will be approved fairly soon. The toxicities are a little bit different, but so far these two have not been compared head-to-head. We expect that they're going to be fairly similar in terms of their efficacy. So if the drugs work in the beginning, what happens? Why do they actually at some point become resistant? So in the last couple of years, at least 5 mechanisms of resistance have been identified. So we have all that complicated wiring in the cell, and new mutations appear. These are the ones that have been identified that are listed over there. Project 3 of Ruth's Spore grant is going to investigate mechanisms of resistance to these BRAF inhibitors, so there is a lot of active research going on in that regard. But one of the thoughts is that if we target BRAF and then we target the next molecule downstream called MEK, maybe we can overcome some of this resistance. So this would be the BRAF, and this is the MEK. So if we target BRAF over here, one of the mechanisms of resistance is that we get increased signaling through CRAF and more activation of MEK. So if we target here and we target there, maybe we have better inhibition of downstream signaling. And this does appear to be a promising approach. This is what we call a waterfall plot of a clinical trial. This was one of the phase 1/2 clinical trials of a combination of the MEK inhibitor and the BRAF inhibitor. So as I told you, when we get a new drug or a new drug combination, we start with different doses, and that's why you see all the different doses over there, because in the beginning we didn't know how much patients can tolerate. This plot is called a waterfall plot. Every bar over here is a patient. If you see the bar going up above the 0 line, it means that there was an increase in tumor burden. So this is percentages. If it goes below the 0 line, there was a decrease or tumor shrinkage. So in the melanoma world, we've now gotten used to seeing waterfall plots like this. Just as recently as a few years ago, if we had a drug which had a 15 or 20% response rate, we were thrilled. We'd never seen anything like this. But with this combination, you can see that the vast majority of the patients actually had tumor shrinkage. And it seems that this combination might result in longer durations of tumor shrinkage than if we give either drug alone, but that still needs to be determined. This is a cartoon that Mario actually already showed you at the beginning, so I'm just going to revise it. We're now shifting gear to the soil of the lawn and going to talk a little bit about the immune system. So if someone has a virus, you have the virus gets presented to a T cell or an immune cell, and when that happens, there's interaction between a bunch of proteins that are kind of represented over here schematically. So this would be this is the antigen presenting cell, and this is the T cell, and these are the different molecules on the cell. So if you have a virus, a viral infection, a lot of things happen, and for a few days a person will get a fever. And then at some point, the fever goes away, the rigors go away, and the joint aches go away. And one of the causes for that is that this molecule called CTLA4 comes to the surface of the cell and starts interfering with one of these interactions. So if we have a molecule that can inhibit that brake, in other words, we're putting a brake on the immune system, we can have continued immune activity. Another one of the brakes is represented down here. It's called PD-1, which stands for Program Death 1. And basically, it causes T cells to start dying off or to stop being active. So if we have something that can inhibit PD-1, we may have ongoing immunity. And if we have ongoing immunity, maybe we can have ongoing activity against those isolated cancer cells that might be sitting there in our body, or to use Dr. Arian's analogy again, the dandelion seeds that are in the lawn. And maybe ongoing immunity can prevent the dandelions growing on one lawn when they may grow on another lawn. This is another figure of the Kaplan-Meier survival curves, as we called it, on the phase 3 trial, comparing the CTLA4 antibody to the alone or with a vaccine to the vaccine alone. And as you can see, there's a significant difference in survival in these treatment arms. So the two treatment arms that got the CTLA4 antibody tended to live longer, and this is the trial that led to the FDA approval of ipilimumab for melanoma. This is the other pivotal trial that was done, a phase 3 trial comparing ipilimumab and dacarbazine to dacarbazine and placebo. So it was a placebo-controlled trial. And there, too, you can see improved survival in the patients that got ipilimumab. So these two trials together led to the full approval of ipilimumab just about a year ago for this disease. This is an example of a CAT scan of the lung. These are the metastases before treatment. This is after treatment, and this patient has had a fairly durable response. These are brain metastases that were not treated with gamma knife therapy but responded to the ipilimumab nonetheless. And we've now learned that actually the response rate in the brain is pretty much the same as response rates in other parts of the body. So exclusion of patients with brain metastases from clinical trials has become a little bit of a problem, seeing that some of these drugs actually do work just as well in the brain metastases as in other places in the body. This drug is not without its issues and challenges. When we talk about a response rate, it's defined as tumor shrinkage of greater than 30%. And the response rate is only 10 to 15%, but yet it really does seem to prolong survival significantly, even in patients whose tumors do not shrink by over 30%. And a lot of our older definitions in oncology are not holding up when we study immune-based therapies. You can sometimes see tumor grow before it shrinks because you get invasion of T cells into the tumor, so it swells. And on a CAT scan, it may look bigger before it gets smaller. In patients who've got brain metastases, sometimes this drug will cause swelling around the metastasis, and that can cause side effects. And then there are the other side effects. So if we activate our immune system against our cancer cells, it's also activated against other cells in the body as well. And this is one of the reasons that we see colitis, which is diarrhea, basically, for the most part, because of all the inflammation in the gut. You can see changes in hormonal systems. There's inflammation in the joints, in the skin, in the form of a rash, the lungs, and so on. We've seen pretty much any kind of inflammation that one can imagine. But some of the studies have shown that there is an association between these side effects and response to therapy. So sometimes we think that these are actually blessed side effects because they indicate that the immune system has been revved up enough to make a difference. And some of these side effects we also see with the anti-PD-1 drugs. So this is a slide that I actually took from one of Dr. Schnoll's talks, because we try to have a standardized approach to patients and to decide what we're going to do with any patient who comes in through the door, which treatment we're going to give first, which one we're going to give second. And these are just some of the considerations that we incorporate into our decision-making process. So firstly, immunotherapy, even though the response rate to the immunotherapies is shorter, they often are very durable. They can last for years. It's still unclear how long the responses to the targeted therapies are going to last. The actual duration of the treatment is different too. For the targeted therapies, when we target the melanoma cell, patients have to keep taking the drug. And when they stop, the tumors grow back. For the immune therapies, we can give a course. We can give an induction course. Sometimes we give a little bit of maintenance. But for the most part, when we start seeing a nice response, if we stop, it'll continue. On the other hand, the responses to the immune-based therapies are slow. So if someone has rapidly growing disease, they may not have enough time for us to get a slow immune activation with subsequent anti-tumor response. So sometimes if you give immunotherapy, the delay in tumor response may actually cause severe symptoms, and we may not be able to complete the course of the immune-based therapy. So we do, sometimes when we have a patient who's got a high tumor burden, we may feel that we don't have enough time to give them an immune-based therapy, and we may use a targeted therapy instead. But the future is going to be on combinations. We think that there may be synergism or added benefit if we use the targeted therapy after immune-based therapy. In other words, we may basically sensitize the patient's immune system and then give the targeted therapies, or we could do it the other way around. So we also think that these targeted therapies also work to some degree by activating the immune system as well. So there's a lot to work on with the combinations of therapies, but at least we've got a backbone to work with, which we didn't have a few years ago. So I'm going to just conclude this part by saying that vemurafenib is a good choice for patients who've got autoimmune disease because we cannot give them the immune-based therapies. It's a good choice for patients who've got large tumor burden. The response rate is high, but not all responses are very prolonged. Combinations may be useful for overcoming emergent resistance, just like we talked about with the MEK inhibitor and the BRAF inhibitor. The ipilimumab response rates are low, but the duration can be longer or very long. Interleukin-2 still remains a good choice for patients with no other medical problems, and we still believe that research is essential because we've not done our job despite making significant progress. So we have a number of clinical research directions that we're embarking on over here. These are more the targeted therapies that we've had in clinical trials. Some of these trials are closed to accrual, but they still have patients on. Some of them are still opening, and some of them are pending. And then the immune-based therapies, particularly the anti-PD-1-based trials, either alone or in combination with the ipilimumab. And then there's a new trial that's going to open next week, which is an anti-PD-1 ligand trial. So instead of targeting PD-1, it targets the PD-1 binding partner in the cancer cell. We're going to have a cell therapy trial. I know there are a few people in this room who are familiar with cell therapy, but I won't have time to go into the details because we'll be here forever. But this should open pretty soon. The menu of clinical trials changes rapidly, so if there's someone sitting here who hears about a great drug and is wondering why they weren't offered that particular drug, sometimes it's because we have slots on one drug on Monday, and then on Thursday we've got slots on a different trial, and that's why sometimes the choices aren't all that clear to a patient, but we do try to pick the best drug or the best trial for a patient when they come in. So just to take a couple more minutes to talk about the PD-1 or the anti-PD-1 and the anti-PD-1 ligand trials. As I said, this is another brake on the immune system. So by inhibiting either PD-1 or PD-1 ligand, we're putting a brake on the brake of the immune system. So the phase 1 trial has been completed. It was conducted over here. It was presented by Dr. Schnoll a couple of years ago at the big oncology meetings, and I'm going to show you some of those results. There were a number of tumor types that were treated, and we used different doses because, as I said before, we don't really know what dose to give a patient, so we start with a lower dose and we escalate. But nice responses were seen at a lot of different dose levels, and it doesn't seem to make much of a difference if a patient gets 1 milligram a kilogram or 10 milligrams a kilogram. But overall, this drug is extremely well tolerated, and I think of all the medications that we use, this anti-PD-1 is probably the drug with the best, what we call therapeutic ratio, which means the best bang for our buck in terms of efficacy to toxicity in oncology. This is a table from that presentation that Mario did a few years ago showing the first patients who actually responded to this drug, and we had never seen a slide like this in oncology where all the patients who'd responded had ongoing responses. Now, granted, since then, some have had relapses, but still a lot of the patients, even in this first cohort, I think this one included, Mario will be able to respond to that, but are still in remission. And like I said, this is really something that we've not seen before in our treatment. So just to end up with a couple of CAT scans, just to demonstrate how dramatic this drug can be, this is a CAT scan of a liver on a patient who had a very large burden of disease when he started. This was a nice response on therapy, and this response is ongoing. I think this is a different patient who's had a complete remission and remains in remission. We've not treated her. So again, it's Dr. Schnoll's patient. She's not been treated now for a couple of years. So we now have a phase 1 trial comparing, looking at the combination of the ipilimumab and the anti-PD-1. This MDX1106 is an acronym for the anti-PD-1 drug. So our hypothesis is that both drugs have single-agent activities. Maybe if we give both drugs, not necessarily at the highest dose, we can get better bang for our buck in terms of activity for toxicity. And this is a scan of a woman who had a very nice response to a single dose of each. This is a different patient who had a nice response and continues to respond. So just to end up with what we call post-surgical therapy in patients with stage 3 disease rather than stage 4 disease, because everything I talked about until now was regarding patients who've got measurable disease on CAT scans. So that's what we call stage 4 disease. Stage 3 is when we have a tumor in the skin and maybe draining lymph nodes, and it's all been resected. So in theory, these are the patients who have the dandelion seeds that have not come up yet. And the question is whether we can activate the soil or activate the immune system to take care of those microscopic metastases that cannot yet be seen on CAT scans, because in order to see a tumor on a CAT scan, you need millions of cells. And maybe if we treat isolated cells, we'll be even more successful. The rationale behind actually going ahead and doing that is that half of the patients who've got stage 3 disease subsequently develop overt metastatic disease or stage 4 disease. So potentially we can improve survival. The standard of care in stage 3 melanoma until now has been interferon, or high-dose interferon we call it. This is somewhat limited therapy. There are a lot of side effects. And there's an ongoing trial at Yale comparing 2 doses of ipilimumab, the CTLA-4 inhibitor, to interferon. It's going to take many, many years until we know the results of those because we don't have tumors to follow. So the only thing we can follow is whether the patient has a recurrence or not, and that sometimes takes a long time. So in conclusion, immune therapies can induce prolonged responses, but they're not void of toxicities. The targeted therapies may be effective in a higher percentage of patients whose tumors have those mutations, but the duration of the response is often limited, not always, and combinations of therapies might be necessary for overcoming resistance, and this is where clinical research remains pivotal. We've made some progress, but we're far from done with our jobs. So we need new approaches for a number of populations, in particular patients whose tumors do not have either a BRAF or an NRAS mutation and who do not respond to immune-based therapies, or patients who've got autoimmune disease and cannot go on these immune-based therapies. We need better predictive biomarkers because these drugs are very expensive and they have side effects, so why would we want to give it to the patients who are not likely to respond? If we had biological markers either in tumors or in blood samples that could help us predict which patients are likely to respond, we'd be able to treat only those that have a better likelihood. So we still need a lot of work in order to improve the cure rates for this disease. And as everybody said, we have a large group of people here who work on melanoma, both the clinicians and the scientific collaborators, and the sources of funding for a lot of this work are mentioned below. So with that, I'll stop, and I'll let Dr. Schnoll come ahead and take questions.